Welcome to the deep dive. Today, we're embarking on a deep dive into a topic that really touches everyone, often with a bit of a shiver down the spine. Cancer.
hmm
It's been this pervasive fear, hasn't it? A true scourge impacting millions globally. Yet, here's something, well, surprising right out of the gate.
Oh,
Despite its terrifying nature, cancer mortality in the U.S. has actually seen a significant and sustained decline over the last few decades of the 20th century and right into the 21st.
that's right. It's a really powerful testament, I think, to the remarkable advances we've made in understanding and treatment.
Absolutely. So our mission today is to truly unpack the world of neoplasia for you. We're going to explore its fundamental characteristics, how it operates, at a molecular level, what causes it, and the cutting-edge ways we're learning to diagnose and fight it.
And it's crucial to remember, cancer isn't just one monolithic thing. It's really many disorders with widely different pathogenesis, natural histories, and responses to treatments.
Exactly. So think of this as your essential shortcut to understanding one of the most critical health topics of our time, hopefully with some surprising facts and maybe just enough humor to keep you hooked.
Let's hope so.
Okay, so we'll unpack this. Because honestly, even the words we use when talking about cancer can feel like a bit of a linguistic minefield.
Agrees. They really can.
So maybe let's start by clarifying some foundational terms like neoplasia.
Right. Neoplasia literally just means new growth. And the abnormal cells that form these new growths, those are called neoplasms.
Okay, new growth. And tumor, that word gets used a lot.
It does. It once just meant any kind of swelling, but now, yeah, it's essentially equated with a neoplasm. It refers to this new abnormal growth of cells.
Got it. And oncology.
That's simply the study of these tumors, these neoplasms, the whole field dedicated to understanding and treating them.
Right. And the modern definition is quite specific, isn't it?
It really is. We now understand a neoplasm as fundamentally a genetic disorder of cell growth triggered by acquired or less commonly inherited mutations affecting a single cell and its clonal progeny.
A single cell and its descendants.
Exactly. And what's crucial to grasp, I think, is that every tumor has two main components. There are the actual neoplastic cells themselves, we call that the parenchyma,
Okay.
and then there's the supporting cast around them, a reactive stroma. That's made up of connective tissue, blood vessels, immune cells, the whole neighborhood.
So the cancer cells and their local environment.
Precisely. And while the tumor's core identity comes from those cancer cells, the parenchyma, its ability to grow and, importantly, spread, is profoundly influenced by that surrounding stroma.
Okay, so if a pathologist is looking at a sample under the microscope, how do they make that absolutely crucial call? That distinction between, okay, this is benign, and the real red flag, this is malignant. What are they zeroing in on?
Well, that distinction is paramount, obviously. Benign tumors are typically localized. They stay put where they started.
Right.
And because of that, they're generally amenable to surgical removal, which usually leads to the patient surviving.
Usually.
Usually.
Yeah.
There's an important, albeit tragic, exception.
Mm.
Even technically benign brain tumors can be fatal. Simply because of where they are, the vital structures they compress, there's just no room.
Right, location, location, location.
Exactly. Now, malignant tumors, or what we commonly just call cancers, they're defined by their ability to invade and destroy adjacent structures.
Yeah.
And critically, their ability to spread to distant sites. That's the process we call metastasis.
And that's the really frightening part.
It is. And the naming conventions can be quite confusing too.
How so?
Well, you have terms like lymphoma, melanoma, mesothelioma, seminoma. They all end with oma, right? Which usually suggests something benign.
Yeah, like a lipoma, a fatty tumor.
Exactly. But all those I just listed, they are in fact malignant cancers.
Wow, okay. That's misleading.
It can be. And conversely, you have things like hemoromas and chorostomas, which sound quite serious, but they're usually just harmless developmental glitches, disorganized tissue.
Okay. So how are malignant tumors properly named then?
Generally, if they arise from solid connective tissues like muscle, bone, cartilage, they're called sarcomas. Fibrosarcoma, osteosarcoma.
Got it. Sarcomas.
Cancers of blood-forming cells are leukemias or lymphomas. We often call those the liquid tumor.
Liquid tumors, right.
And then malignant neoplasms that come from epithelial cells, the cells lining organs and cavities, skin, those are called carcinomas, like squamous cell carcinoma or adenocarcinoma. That's the most common category.
Carcinomas. Okay, sarcomas, leukemias, lymphomas, carcinomas. That helps. All right, so we've clarified the names and the huge difference between benign and malignant. But what's actually happening inside these cells? What are those microscopic clues pathologists look for to understand a tumor's personality, its potential for aggression?
Yeah, the core concept here is differentiation. It basically describes how much the cancer cells still look and act like their normal, healthy counterparts.
So, how grown up or specialized they seem?
Kind of, yeah. And the opposite, a lack of differentiation, we call that anaplasia.
Anaplasia, lack of differentiation.
Exactly. Now, benign tumors are almost always well differentiated.
Yeah.
Sometimes they look so much like normal tissue, like lipoma cells can look almost exactly like normal fat cells, that it's only their growth into a distinct lump that tells you they're neoplastic.
Okay.
Malignant tumors, though, they span a whole spectrum. They can be well differentiated, where their malignancy is really only revealed by their invasive behavior.
But they look fairly normal, but they're breaking boundaries?
Precisely. Or they can be highly anaplastic, very poorly differentiated. And that lack of differentiation, that anaplasia, is a very strong predictor of aggressive behavior.
So, what are the visual cues? What does anaplastic actually look like?
Pathologists look for several telltale changes. One is pleomorphism. Pleomorphism. It just means significant variation in the size and shape of the cells. You can get these abnormally large tumor giant cells that really stand out.
Okay, so weird shapes and sizes.
Right. Cancer cells also characteristically have abnormal nuclear morphology. The nucleus, the cell's control center, gets all distorted. It becomes disproportionately large compared to the rest of the cell. The chromatin inside looks clumpy. The nucleoli can be huge.
So the control center looks messed up.
Very much so. We also see increased and atypical mitosis. Mitosis is cell division, right? So cancer cells are dividing rapidly but often incorrectly, leading to abnormal chromosome counts and structures.
Fast and faulty division.
Exactly. And finally, there's loss of polarity. Anaplastic cells just grow in a completely disorganized mess. They lose their normal orientation to each other, to the basement membrane. It's architectural chaos.
Wow. It's incredible how those visual clues paint such a picture. Do these cells still do their original jobs, or do they lose function?
It varies. Well-differentiated tumors often do retain some normal functions. Endocrine tumors might still pump out hormones, sometimes too many. Squamous cell carcinomas might still make keratin,
Okay.
but highly anaplastic, undifferentiated tumors, they typically lose those specialized functions.
Yeah.
Interestingly, though, sometimes they acquire totally new, unexpected functions. Like certain lung cancers starting to produce corticotropin, a hormone usually made way up in the pituitary gland.
That's bizarre. A lung cell acting like a pituitary cell?
It shows how scrambled the controls can get. And this whole transformation, it isn't usually a sudden flip of a switch. It's often a gradual continuum of changes.
A slippery slope.
Kind of. It can begin with metaplasia. That's when one type of mature cell gets replaced by another type, often as an adaptation to some chronic injury or stress.
Like smoker's lungs.
That's a classic example, where the normal ciliated columnar cells get replaced by tougher squamous cells. Or Barrett esophagus, where chronic acid reflux causes the normal squamous lining of the esophagus to be replaced by glandular epithelium, more like the stomach lining.
And is that dangerous?
Well, the metaplasia itself isn't cancer, but it's considered often a prelude to malignant transformation. It creates sort of unstable ground.
Okay, so what's next on that slope?
That would be dysplasia, which literally means disordered growth.
Disordered growth.
Yeah, this is particularly seen in epithelial tissues. It's characterized by some of those features we talked about: irregular cell shapes, large dark nuclei, loss of orderly differentiation, but it's still confined.
Is dysplasia cancer?
Not necessarily. It's definitely a precursor, but it's important to remember that dysplasia does not always progress to cancer. And sometimes, if you remove the underlying cause, like the chronic irritation, it can even be reversible.
Okay, so it's a warning sign, but not always a final step.
Exactly. But then we get to a really critical point.
Which is?
Carcinoma in situ.
In situ, meaning in place.
Precisely. This is when the dysplasia becomes severe. It involves the full thickness of the epithelium. All the cells look cancerous. But crucially, at this stage, the lesion has not yet penetrated the basement membrane. That's the thin layer supporting the epithelium.
So it looks like cancer, acts like cancer, but it hasn't broken out of its original layer yet.
You got it. These in situ cancers have all the microscopic features of malignancy, but they haven't invaded. However, and this is key, unless treated, they have a high probability of progressing to invasive cancers. It's like the final warning before the breakout.
And that ability to locally invade and then metastasize, spread, that's the defining trait, the one that really dictates a patient's fate often. What's the difference in how benign and malignant tumors interact with the tissue right around them?
Yeah, it's a night and day difference.
Hmm.
Benign tumors are typically cohesive, expansile, well-demarcated masses. They grow by pushing surrounding tissue aside, often forming a capsule around themselves. They usually have distinct cleavage planes, which makes them relatively easy for a surgeon to shell out, like fibroadenoma in the breast.
Like a distinct lump you can remove cleanly?
Mostly, yes. Malignant tumors, on the other hand, are generally poorly demarcated. They don't push, they infiltrate. They aggressively invade and destroy the surrounding normal tissue, spreading out in these little tendrils. It's often described as a crab-like pattern of growth. Cancer actually comes from the Greek word for crab.
Ah, I see. So that makes surgery much harder.
Incredibly difficult.
Yeah.
You often can't see the edges clearly, which is why surgeons usually need to remove a wide margin of apparently normal tissue around the tumor just to try and get all those infiltrating cells.
Right. And then there's the M word, metastasis.
Metastasis, yes. That is the event that unequivocally marks a tumor as malignant. It's the spread to distant sites.
And how often does that happen by the time someone is diagnosed?
Well, the estimates are that about 30% of solid tumors are already metastatic when they're first found. And obviously, this spread strongly reduces the possibility of cure.
That's sobering.
It is. It's a complex, often unpredictable process. And honestly, the only hope for controlling cancer lies in learning more about its causes and pathogenesis. We have to understand how it spread to stop it.
So once these malignant cells break free and get on the move, how do they travel? What are the routes they take?
There are three main pathways. The first is direct seeding of body cavities or surfaces.
Seeding, like planting seeds.
Kind of, yeah. This happens when a neoplasm penetrates into an open field, usually the peritoneal cavity, the space around your abdominal organs. This is quite common with ovarian carcinomas. They can shed cells that then implant all over the peritoneal surfaces, creating this heavy cancerous coating.
Wow.
Or, in some really dramatic, fascinating but grim cases, you can get mucus-secreting appendiceal carcinomas that just fill the entire peritoneal cavity with this thick, gelatinous neoplastic mass. It's called pseudomyxoma peritoni.
Goodness. Okay, so that's direct seeding. What's next?
The second, and probably the most common pathway for initial dissemination of carcinomas, is lymphatic spread.
Through the lymph system.
Exactly. Tumors often follow the natural drainage routes of the lymphatic vessels. So, for instance, breast cancer frequently spreads first to the lymph nodes in the armpit, the axillary nodes.
Right.
And we use this knowledge clinically with a technique called sentinel lymph node biopsy. The idea is to find the very first lymph node, the sentinel, that receives drainage from the tumor site. By checking that node for cancer cells, we can get a good idea if the cancer has started to spread regionally, and it helps guide treatment.
Okay, makes sense. Check the first stop on the train line.
Pretty much. And the final route is hematogenous spread.
Through the blood.
Correct, spread through the bloodstream. This is the typical route for sarcomas, but it's also very common for carcinomas later on. When tumor cells invade veins, they get swept along and often lodge in the first capillary bed they encounter.
Which explains why certain organs are common sites for metastasis.
Absolutely. It explains why the liver and the lungs are most frequently involved by hematogenous spread, because blood from most of the body drains through one or both of those organs eventually. But we also see something called organ tropism. Some cancers seem to have a preference. They preferentially spread to specific sites, even if it's not the first place they'd logically arrive.
Like they have a destination in mind.
It seems that way sometimes. For example, prostate and breast cancers frequently spread to bone. Lung cancers tend to go to the adrenal glands and the brain. There are molecular reasons for this, involving adhesion molecules and chemical signals.
Fascinating.
And sometimes you see really remarkable patterns. Renal cell carcinoma, kidney cancer, can sometimes grow right up the main vein from the kidney, the inferior vena cava, in this continuous snake-like fashion, sometimes reaching all the way into the right side of the heart.
That's incredible and terrifying.
It really highlights the invasive potential. Now, if we zoom out a bit and connect all this to the bigger picture, the modern era of cancer biology has revealed what we call the hallmarks of cancer. There are about 8 fundamental changes in cell physiology that really almost all cancers display to some degree.
8 core features or abilities that define cancer.
Exactly. And what's really insightful is that these hallmarks are often enabled by 2 underlying conditions. One is genomic instability. the cancer's DNA getting messed up, which speeds up its
The
evolution.
mutator phenotype we hear about.
Right. And the other is chronic inflammation, which can actually create a supportive, nurturing environment for the tumor.
Okay, so let's break down these hallmarks. What are the first ones?
Well, the first two are really about growth control. Hallmark 1 is self-sufficiency in growth signals, and Hallmark 2 is insensitivity to growth inhibition. Basically, cancer cells learn to grow when they shouldn't, and they ignore signals telling them to stop.
Right.
They acquire oncogenes, which are essentially mutated or overexpressed versions of normal genes called proto-oncogenes that usually promote controlled growth. These mutated oncogenes function autonomously, having lost dependence on normal growth-promoting signals.
So it's like a car with the accelerator pedal jammed down, constantly pushing forward, even without your foot on it.
That's a perfect analogy, yes.
Yeah.
They don't need the normal go signals anymore.
What are some prime examples of these stuck accelerators in cancer?
There are many ways they achieve this. Some cancer cells become entirely self-sufficient by creating autocrine loops. They actually synthesize their own growth factors, essentially telling themselves to grow constantly. Glioblastomas, a type of brain tumor, can do this with PDGF.
Making their own fuel.
Exactly. Others involve mutated or amplified growth factor receptors on the cell surface, like ERBB1, which encodes the EGFR receptor, found mutated in some lung adenocarcinomas, or ERBB2, better known as HER2, which is amplified, meaning there are too many copies of the gene in about 20–25% of breast cancers.
And HER2 is a target for therapy, right? Like Herceptin.
It is, yes, a major success story for targeted therapy. But even there, resistance often develops, which highlights the cancer's relentless adaptability.
Always evolving.
Always. Then you have key signaling proteins inside the cell. A classic example is RAS. RAS proteins are like molecular switches and mutations, which are found in maybe 15–20% of all human tumors, but up to 90% in pancreatic cancer, essentially trap the RAS protein in its active on state, constantly sending growth signals.
90% in pancreatic cancer. Wow.
It's a huge driver there. We also see mutations in BRAF, another signaling protein, in nearly all hairy cell leukemias and about 60% of melanomas. And then there's MYC, which is the master transcriptional regulator of cell growth. It controls lots of genes involved in growth and metabolism, and it often gets deregulated by chromosomal translocations, like in Burkitt lymphoma, or by gene amplification, as in neuroblastomas.
Okay, so lots of ways to jam the accelerator. What about the other side of the coin, disabling the brakes? That's Hallmark 2, insensitivity to growth inhibition.
Exactly. This involves inactivating tumor suppressor genes, which normally act as the crucial brakes on cell proliferation.
The brakes.
The absolute classic example here is the retinoblastoma gene, or RB. The RB protein is a key negative regulator of the cell cycle. It essentially guards the gate between the resting phase, G1, and the DNA synthesis phase, S. When it's active, the cell stays put. When it gets inactivated, the cell progresses toward division. And RB is directly or indirectly inactivated in most human cancers.
Most human cancers, that's fundamental.
It really is. And the way it often gets inactivated follows Knudsen's famous two-hit hypothesis, which he developed studying retinoblastoma, the eye cancer.
The two-hit hypothesis.
Right. In familial cases, kids inherit one defective copy of the RB gene in all their cells. So they only need one more hit, a spontaneous mutation in the other copy in a single retinal cell, to lose RB function completely and develop the cancer. That's why it often affects both eyes and occurs earlier. In sporadic cases, someone starts with two good copies, so they need two separate random somatic hits in the same cell to knock out both copies. Much rarer, usually one eye, later onset.
That makes perfect sense. 2 strikes and you're out for the tumor suppressor.
Precisely. And it's also fascinating how certain viral oncoproteins, like the E7 protein from high-risk human papillomavirus HPV, can specifically bind to and inactivate the RB protein. The virus disables the brakes for its own purposes.
Wow. Okay, so RB is a master brake. Is there another big one?
Oh, yes. Perhaps the most famous tumor suppressor of all is TP53. It encodes the p53 protein, often called the guardian of the genome.
Guardian of the genome, I've heard that.
It's a fitting name. TP53 is the most frequently mutated gene across all human cancers, found mutated in over 50% of them. Lung, colon, breast, you name it.
Over half. Why is it so important?
Well, individuals who inherit one mutated TP53 allele have a condition called Li-Fraumeni syndrome. They have a hugely increased risk of developing a whole spectrum of cancers, often at a much earlier age.
Li-Fraumeni. Okay.
What p53 does is act as a central hub, a focal point of a large network of signals that sense cellular stress. Things like DNA damage, lack of oxygen, oncogene activation. p53 detects these problems.
And what does it do about them?
It has a few options. It can temporarily halt the cell cycle arrest to give the cell time to repair the damage. It can induce senescence, a permanent state of arrest. Or, if the damage is too severe and irreparable, it can trigger apoptosis programmed cell death, basically telling the damaged cell to commit suicide for the good of the organism.
So it's quality control, repair or remove.
Exactly. And crucially, the loss of p53 function is devastating. It means damaged cells don't get arrested, they don't die, they survive, accumulate more mutations leading to that mutator phenotype we mentioned, and they often become resistant to chemotherapy and radiation because many of those treatments work by causing DNA damage that should trigger p53-dependent death.
So losing p53 is like disabling the emergency response system and the self-destruct mechanism.
That's a great way to put it. And just like RB, p53 can also be targeted by viruses. The HPV-E6 protein specifically promotes the degradation of p53.
Unbelievable. It seems like hitting RB and p53 is a major strategy for cancer, whether through mutation or viruses.
It absolutely is. They are central pillars of growth control.
So it really sounds like this is a fundamental concept. Cancer is about pushing the growth accelerator and disabling the body's natural brakes. Are there other critical tumor suppressors we should know about besides RB and TP53?
Oh, definitely. While RB and TP53 are sort of the prototypes, there are many others playing vital roles. There's APC, adenomatous polyposis coli. That gene is mutated in maybe 70–80% of sporadic colorectal carcinomas. It's involved in a key signaling pathway called WNT, which controls cell fate and adhesion.
APC and colon cancer, right?
Right. Then there's TGF-beta, transforming growth factor beta. Normally, it's a potent growth inhibitor, but mutations that block its signaling are common in many cancers. And paradoxically, in some later-stage cancers, TGF-beta can actually switch sides and promote invasion and metastasis.
Wow, a double agent.
Kind of, yeah. PTIN is another important one. It acts as a brake on a major pro-survival signaling pathway called PI3KKT, and loss of PTIN function is seen in lots of cancers, like endometrial, prostate, and glioblastoma. And VHL, the von Hippel-Lindau gene, it's involved in sensing oxygen levels. When it's mutated, as in a common type of kidney cancer, clear cell renal cell carcinoma, cells behave as if they're starved of oxygen, even when they're not, leading them to produce factors that promote blood vessel growth, angiogenesis.
Ah, linking back to oxygen sensing.
Exactly. So yes, it's a whole network of breaks, and cancer finds ways to disable many of them, not just RB and P53.
Okay, let's move to the next hallmark. You mentioned altered metabolism, the Warburg effect.
Yes, hallmark number 3, altered cellular metabolism, famously known as the Warburg effect, after Otto Warburg, who first described it decades ago. What's really intriguing here is that even when oxygen is plentiful, cancer cells show this distinctive metabolic shift.
Even with oxygen, because normally cells use oxygen for efficient energy production, right?
Yeah.
Oxidative phosphorylation.
Exactly, that's the efficient way. But cancer cells, they tend to rely much more heavily on glycolysis, breaking down glucose anaerobically, followed by conversion of the end product, pyruvate, into lactate. It's basically fermentation, even in the presence of oxygen. That's why it's sometimes called aerobic glycolysis.
Why would they do that? It's less efficient at making ATP, the energy currency.
It is less efficient for ATP per glucose molecule, yes, but cancer cells are not primarily limited by ATP. They are ravenous for glucose. They take up huge amounts of it. And this high rate of glycolysis, even if less efficient for ATP, allows for the rapid diversion of metabolic intermediates into pathways that synthesize macromolecules, nucleotides, lipids, amino acids, the building blocks they need for rapid cell growth and division.
Ah, so it's not just about energy. It's about raw materials for building new cells quickly.
Precisely. They prioritize biomass production, and this glucose hunger of tumors is actually what we exploit clinically in PT scans.
PET scans, right? They inject radioactive glucose.
Exactly. A glucose analog called FDG. Tumors gobble it up much faster than most normal tissues, so they light up on the scan, helping us find tumors and assess treatment response.
Clever. Okay, what about hallmark 5? Limitless replicative potential, immortality.
Yes, essentially achieving cellular immortality, or at least vastly extending their lifespan. Normal human somatic cells can't divide forever. They have a finite number of divisions, maybe 50, 70 times, a phenomenon called replicative senescence.
And that's linked to telomeres, right? The caps on chromosomes.
Exactly. Telomeres are protective DNA sequences at the ends of chromosomes. With each cell division, they get a little bit shorter because DNA replication can't quite copy the very ends. Eventually, they get critically short, and that signals the cell to stop dividing to enter senescence. It's a built-in aging mechanism.
A biological clock.
Pretty much. Now, if cells lose their checkpoint controls, particularly p53, they might bypass senescence even with short telomeres. But then they often run into a bigger problem called mitotic crisis.
Mitotic crisis. Sounds bad.
It is. With critically short telomeres, the unprotected chromosome ends can fuse together, break during cell division, fuse again. These bridge fusion breakage cycles lead to massive chromosomal instability and usually trigger cell death.
So how do cancer cells avoid this? How do they achieve immortality?
The vast majority of them, maybe 85 to 95%, manage to evade mitotic crisis by reactivating an enzyme called telomerase.
Telomerase.
Yes. Telomerase is an enzyme that can add back DNA repeats to the ends of telomeres, essentially maintaining their length.
Yeah.
It's normally active in germ cells and stem cells, but turned off in most somatic cells. By turning telomerase back on, cancer cells can keep their telomeres stable, bypass senescence and crisis, and achieve limitless replicative potential. They gain eternal youth, in a sense.
So they find the enzyme that resets the clock.
In essence, yes. And there's also this related concept of cancer stem cells. The idea is that within a tumor, there might be a small population of cells that has stem cell-like properties, including self-renewal. These cells might be responsible for maintaining the tumor long-term, and importantly, they are hypothesized to be particularly resistant to therapeutic targeting.
Why resistant?
Partly because they might divide relatively slowly, making them less susceptible to drugs that target dividing cells, and they might also express higher levels of drug resistance factors, like the MDR1 pump that actively spits drugs out of the cell. Targeting these elusive cancer stem cells is a major focus of research.
Right, hitting the root of the problem. Okay, hallmark 6. Sustained angiogenesis. Building blood vessels.
Yes, the ability to induce the formation of new blood vessels, or neoangiogenesis. Solid tumors simply cannot grow beyond a tiny size, maybe 1 to 2 millimeters in diameter, without getting their own blood supply. They need oxygen and nutrients, and a way to remove waste products.
So how do they signal for new vessels?
A key trigger is hypoxia low oxygen levels, which inevitably occurs in the center of a growing tumor mass. Hypoxia stabilizes a protein called HIF1, hypoxia-inducible factor 1 alpha.
HIF1.
Right. And HIF1 then turns on the expression of several pro-angiogenic factors, most importantly VEGF, the vascular endothelial growth factor. VEGF signals nearby endothelial cells, the cells lining existing blood vessels, to proliferate, migrate, and form new capillaries that sprout towards the tumor. Basic fibroblast growth factor, BFTF, is another important player.
So lack of oxygen triggers the call for help.
It does. Also, loss of p53 function can increase VEGF production, and activation of oncogenes like RAS or MYC can also upregulate angiogenic factors. It's another way that core genetic changes contribute to the hallmarks.
It really sounds like tumors are constantly building their own highways for growth and supply lines. Now, we have therapies that target angiogenesis, right, like bevacizumab, Avastin. How well do they work?
Yes, we do have angiogenesis inhibitors,
Yeah.
like bevacizumab, which is an antibody against VEGF. They're used in treating several types of cancer, often in combination with chemotherapy. And they can definitely provide benefit. They can prolong life for patients with certain advanced cancers. But they are not curative. Tumors often become resistant. They might start using other angiogenic factors besides VEGF or find other ways to get blood supply. It implies that there are escape routes. So, while inhibiting angiogenesis is a valuable strategy, it's rarely a complete solution on its own. It's a constant battle against the tumor's resourcefulness.
Always finding a workaround. Okay, now we get to hallmark 7, invasion and metastasis, which we touched on earlier, and hallmark 8, evasion of immune surveillance. Let's dive deeper into the molecular mechanisms of invasion first. You said it's an active 4-step process.
Yes, it's not just passive spreading. Cancer cells have to actively break down barriers and move.
That's step 1.
Step 1 is the loosening up of the connections between the tumor cells themselves. Normally, epithelial cells, for instance, are tightly bound together by adhesion molecules, especially one called E-cadherin. It acts like cellular glue.
E-cadherin.
Right. In many carcinomas, E-cadherin function is lost, often due to mutations in the E-cadherin gene or the genes that regulate it. This allows the cells to detach from the main tumor mass.
So the glue dissolves.
Essentially. This is often linked to a fascinating process called epithelial mesenchymal transition, or EMT.
EMT, you mentioned that.
Yes. This is where epithelial cells, which are normally stationary and polarized, undergo a transformation. They lose their epithelial characteristics, like E-cadherin expression, and gain features of mesenchymal cells, like fibroblasts becoming more elongated, motile, and invasive. They literally change their identity to become better invaders. This process is driven by specific transcription factors like snail and twist, and EMT is now considered integral to the metastasis of carcinomas.
Wow, a complete identity shift to enable spread. Okay, step 2.
Step 2 is degradation of the extracellular matrix, or ECM. The ECM includes the basement membrane that underlies epithelia and the connective tissue stroma. Tumor cells need to breach these physical barriers.
How do they do that?
They, or sometimes the surrounding stromal cells they recruit, secrete powerful proteolytic enzymes. The most important family are the matrix metalloproteinase, or MMPs. These enzymes literally chew up components of the ECM, like collagen and laminin, clearing a path for invasion.
Like chemical bulldozers.
A good analogy. Step 3 is changes in attachment to the now remodeled ECM components. As the ECM is broken down and altered, tumor cells adapt their own adhesion molecules, particularly integrins, to be able to bind to these newly exposed or modified matrix proteins, which helps them gain traction.
So they adapt their grip to the changing terrain.
Exactly. And the fourth and final step is migration and invasion, the actual locomotion. Tumor cells actively move into the degraded matrix, propelling themselves forward using their internal cytoskeleton, often following chemical signals or gradients.
Purposeful movement?
Very much so. Now, once they get into the bloodstream or lymphatics, they become circulating tumor cells, or CTCs. It's actually a very harsh environment for them. Most CTCs die pretty quickly.
Really? I thought getting into the blood was the main hurdle.
It's a big hurdle, but survival in circulation is tough too. Mechanical stress, immune attack. However, CTCs that survive often do so by traveling as multicellular clumps or aggregates, sometimes coated with platelets. This seems to enhance their survival and their ability to get lodged in distant capillary beds.
Traveling in packs for protection.
Seems like it. And where they arrest, where they get stuck, is often related simply to the body's vascular plumbing, which is why the liver and the lungs are most frequently involved, as the first capillary bed encountered from many sites.
Right, the first filter they hit.
But then there's also that phenomenon of organ tropism, where certain cancers preferentially metastasize to specific organs, which can't be explained by plumbing alone. This is often referred to as Paget's seed soil hypothesis from over a century ago.
Seed and soil. The cancer cell is the seed, the organ is the soil.
Exactly. The idea is that successful metastasis requires not just the arrival of the seed, the cancer cell, but also a receptive soil, the microenvironment in the target organ. This involves specific interactions between the tumor cells and the local environment. For example, prostate and breast cancer cells often express adhesion molecules like CD44 or chemokine receptors that help them bind specifically to endothelial cells in bone marrow capillaries.
So they have the right key for that particular lock.
That's the idea. And even once a cancer cell has arrested in a distant organ, it doesn't necessarily start growing right away. It might enter a state of tumor dormancy, sometimes for years or even decades.
Dormancy, just sitting there quietly.
Yes. We don't fully understand why, but they might lack the right signals or be held in check by the local environment or the immune system. Successful colonization? The actual growth of a secondary tumor often requires further adaptation and complex feedback loops between the tumor cells and the local stromal cells.
Can you give an example?
A classic one is breast cancer metastasis to bone. The breast cancer cells often secrete a protein called PTHrP, parathyroid hormone-related protein. PTHrP stimulates bone cells called osteoclasts to break down bone. This bone resorption releases growth factors, like TGF-α, that were stored in the bone matrix, and these growth factors then stimulate the proliferation of the breast cancer cells. It's a vicious cycle that promotes tumor growth and bone destruction.
Wow, they manipulate the local environment to feed themselves.
You absolutely do. It's a complex interplay.
Okay, now this next hallmark, number 8, brings us to something incredibly exciting in recent cancer therapy. The promise of immunotherapy, evasion of immune surveillance. What exactly does that mean, and how does our immune system normally deal with potential cancers?
Well, the central idea of immune surveillance, proposed decades ago by Burnett and Thomas, is that our immune system is constantly patrolling the body, constantly scans the body for emerging malignant cells and destroys them.
Like a security force looking for trouble.
Exactly. And there's good evidence for this. The most compelling is probably the fact that immunodeficient patients, like those with AIDS or transplant recipients on immunosuppressive drugs, have a significantly increased risk for developing cancer, particularly types associated with oncogenic viruses, but also some others.
So a weakened immune system leads to more cancer. Makes sense. What does the immune system recognize on cancer cells? How does it spot them?
It recognizes specific molecules on the cancer cells as foreign or non-self. These are broadly called tumor antigens.
Tumor antigens. Okay. What kinds are there?
There are several classes. Perhaps the most important for modern immunotherapy are neoantigens.
Neoantigens, new antigens.
Exactly. These are completely novel proteins that arise from the mutations, both the driver mutations causing the cancer and the random passenger mutations that accumulate in the tumor's DNA. Because these proteins are unique to the tumor and not present in normal cells, the immune system, particularly T cells, can recognize them as foreign. And interestingly, tumors with a higher burden of mutations, like melanoma or smoking-induced lung cancer, often tend to respond better to immunotherapy, presumably because they have more neoantigens for the immune system to target.
More targets, better response, makes sense. What other kinds of antigens?
The immune system can also recognize normal cellular proteins that are either wildly overexpressed in the tumor compared to normal tissues or aberrantly expressed, meaning expressed in the wrong place or at the wrong time. An example is tyrosinase, an enzyme involved in melanin production, which is overexpressed in melanoma cells. Or there are cancer testis antigens, like the MAGE family, which are normally only expressed in sperm precursor cells, which don't express MHC molecules to show antigens, but get turned on in various cancers.
So proteins that shouldn't be there or are there in massive amounts?
Right. And finally, a very important category, especially historically, are tumor antigens produced by oncogenic viruses. Proteins like the E6 and E7 proteins of HPV or various proteins from the Epstein-Barr virus, ABV, are foreign viral proteins expressed in the infected cancer cells, making them prime targets for the immune system.
Okay, so the immune system can see cancer cells. So the big question is, how do tumors manage to survive and grow? How do they outwit the host immune system? That's the hallmark.
They employ a whole arsenal of clever evasion strategies. It's really an evolutionary arms race.
What are some of the tactics?
Well, one simple one is just selective outgrowth of antigen-negative variants. If a tumor clone arises that happens to lose expression of the main antigen the T cells are recognizing, it can escape immune attack and proliferate. Darwinian selection within the tumor.
Becoming invisible.
Right. Another common strategy is to lose or reduce the expression of MHC class I molecules. MHC molecules are like the display platforms that present antigens, like neoantigens or viral proteins, to cytotoxic T cells. If you take away the display platform, the T cells can't see the antigen, even if it's there.
Hiding the evidence.
Exactly. But perhaps the most significant mechanism, and the one that's revolutionized therapy recently, involves immune checkpoints.
Checkpoints. These are the brakes on the immune system, right?
Precisely. The immune system has natural brakes, or checkpoints, to prevent overactivation and autoimmunity. Proteins like CTLA4 on T cells, or PD-1 on T cells, and its ligand PD-L1, which can be expressed by tumor cells or other cells in the tumor microenvironment. When these checkpoint pathways are engaged, they deliver inhibitory signals that shut down T cell activity.
And tumors exploit this.
They absolutely do. Many tumors actively inhibit tumor immunity by upregulating these negative regulatory checkpoints, particularly PD-L1. By displaying PD-L1 on their surface, they can engage PD-1 on arriving T cells and basically tell them, nope, nothing to see here, stand down. They actively put the brakes on the anti-tumor immune response.
And this is truly the exciting part for patients, isn't it?
Sure.
Because the new therapies, the checkpoint inhibitors, are antibodies that block these interactions. They literally remove the brakes on the immune system, allowing your own T cells to wake up and recognize and fight the cancer.
That's exactly right. Antibodies that block CTLA4 or block the interaction between PD-1 and PD-L1 have shown remarkable, sometimes durable responses in patients with various advanced cancers. These checkpoint inhibitors are now approved for treatment of patients with advanced stage solid tumors and certain forms of lymphoma.
It's been a game changer for many, but you said earlier only a subset of tumors respond, maybe 25–40%. Why not all?
That's the million-dollar question we're still trying to fully answer. It likely depends on many factors. Whether the tumor has enough neoantigens to be recognized in the first place, the presence and type of immune cells already within the tumor microenvironment, the levels of checkpoint expression, and probably many other resistance mechanisms we're still uncovering.
Okay. Are there other ways tumors evade immunity besides checkpoints?
Oh, yes. They can secrete immunosuppressive factors directly into the microenvironment, things like TGF-A, IL-10, VEGF, which can broadly dampen immune responses. They can also recruit or induce the expansion of specific types of immune cells that are actually suppressive, like regulatory T cells or TREGs, which actively shut down other effector T cells.
So they can create a whole suppressive neighborhood.
They can. Despite these challenges, though, the successive checkpoint blockade has generated, quite rightly, tremendous excitement. The possibility of achieving long-term remission, maybe even cures in some patients, potentially due to the activation of long-lived memory T cells that remember the tumor, is incredibly promising.
But there are side effects too, right? Autoimmunity.
Yes, that's the main challenge. By releasing the brakes on the immune system generally, these inhibitors can sometimes lead to the immune system attacking normal tissues, causing autoimmunity and/or inflammatory damage to organs, things like colitis, hepatitis, pneumonitis, thyroid problems. Managing these immune-related adverse events is a critical part of using these therapies.
A balancing act. Okay, this brings us to those crucial enabling characteristics you mentioned earlier. The first was genomic instability. This is where that mutator phenotype comes in, right? Speeding up cancer's evolution, giving it the raw material for all those hallmarks. What causes this profound instability in a cancer cell's genetic code?
There are several major routes to genomic instability. Perhaps the preeminent source we keep coming back to is p53 dysfunction.
The guardian being asleep on the job again.
Exactly. Without p53 to enforce cell cycle arrest or apoptosis in response to DNA damage, especially when telomeres are short, cells can enter those disastrous fusion breakage cycles.
Yeah.
This leads to widespread chromosomal chaos and aneuploidy, abnormal chromosome numbers, deletions, amplifications, complex rearrangements. It's a major driver of the large-scale genomic alterations seen in many cancers.
Okay, so failed quality control leads to chaos. What else?
Then there are inherited or acquired defects in DNA repair mechanisms themselves. We have multiple pathways to fix different types of DNA damage. If one of these pathways is broken, mutations accumulate much faster.
Like specific syndromes.
Yes, there are several inherited cancer predisposition syndromes caused by defects in DNA repair. Xeroderma pigmentosum, for example, involves defects in nucleotide excision repair, which fixes damage caused by UV light. Patients are incredibly sensitive to sunlight and have a hugely increased risk of skin cancers. Hereditary non-polyposis colon cancer, HNPCC, also known as Lynch syndrome, is caused by inherited defects in DNA mismatch repair, the system that fixes errors made during DNA replication. This leads to instability in short, repetitive DNA sequences, microsatellites, and a high risk of colon, endometrial, and other cancers.
Lynch syndrome, okay.
And then, of course, there are the famous BRCA1 and BRCA2 genes. Mutations in these genes impair the repair of DNA double-strand breaks through homologous recombination, leading to a high risk of breast, ovarian, prostate, and pancreatic cancers.
BRCA1 and 2, crucial for DNA repair.
Absolutely. It's not just inherited defects either. Sometimes even the enzymes that replicate DNA, the DNA polymerases, can lose their proofreading function, leading to a massive increase in mutations. So in those heavily mutated of all human cancers arise this way, often called ultramutated tumors. Interestingly, like tumors with mismatch repair defects, these often respond very well to immune checkpoint inhibitors, likely because all those mutations create lots of neoantigens.
More mistakes, more targets for the immune system.
Seems to be the case. And finally, there's a special kind of regulated genomic instability that normally occurs in developing B and T lymphocytes. Processes like VDJ recombination, which creates antibody and T cell receptor diversity, and class switch recombination, which changes antibody type, involve deliberately cutting and pasting DNA. Sometimes errors during these processes can lead to oncogenic mutations or translocations that cause lymphomas and leukemias.
So even a normal process can go wrong and cause cancer.
In certain circumstances, yes.
What kind of large-scale chromosomal changes result from all this instability?
We see several characteristic types. Translocations, where pieces of different chromosomes break off and swap places. This can create fusion genes that encode novel oncoproteins.
Like the Philadelphia chromosome.
Exactly, the classic example. A translocation between chromosomes 9 and 22 creates the BCR-ABL fusion gene, the driver of chronic myeloid leukemia, CML. And crucially, this fusion protein is the target of highly effective kinase inhibitor drugs like imatinib, Gleevec. Another example is the PML-RRA fusion in acute promyelocytic leukemia, APML, which is targeted by a differentiation therapy using retinoic acid and arsenic. So identifying these specific translocations is critical for diagnosis and therapy.
Okay, translocations creating new bad actors. What else?
We also see deletions. where chunks of chromosomes are lost. This often results in the loss of tumor suppressor genes located in that region, like RB or VHL or P53. But deletions can also sometimes activate oncogenes, maybe by removing a nearby regulatory element that was keeping them quiet.
Loss of breaks, or sometimes activation of accelerators.
Right. And then there's gene amplification, where specific segments of DNA containing an oncogene are duplicated many, many times, leading to massive overexpression of that oncogene. A well-known example is amplification of the NMYC gene in neuroblastoma, which is linked to very aggressive disease and poor prognosis, or amplification of ERBB to HER2 in breast cancer, which we already discussed as being targetable. NMYC HER2 amplification. Okay.
And more recently, scientists have discovered a really dramatic phenomenon called chromothripsis.
Chromo what?
Chromothripsis. It literally means chromosome shattering. It seems that in some catastrophic event, possibly during mitosis, a single chromosome, or sometimes a few chromosomes, just fragments into tens or even hundreds of pieces, which are then stitched back together in a completely random, haphazard order. It's genomic chaos on a massive scale, seen in a significant fraction of cancers, especially bone cancers.
Shattered and randomly reassembled. That sounds incredibly destructive.
It is. It can lead to simultaneous loss of tumor suppressors and activation of oncogenes on that chromosome. Okay, so genomic instability is a huge enabler. What was the other one you mentioned? Inflammation?
Yes, cancer-promoting or cancer-enabling inflammation. This is a really fascinating area. For a long time, we've known that chronic inflammation predisposes to cancer, like chronic hepatitis leading to liver cancer, or H. pylori infection leading to stomach cancer. But now we understand that even cancers not initially caused by inflammation often recruit inflammatory cells into the tumor microenvironment, and these cells can actively help the cancer grow and spread. Cancers can be likened, in some ways, to wounds that do not heal.
Wounds that don't heal, meaning they constantly have this inflammatory response going on.
Exactly. And the infiltrating inflammatory cells, macrophages, neutrophils, lymphocytes, mast cells, can profoundly modify the tumor cells and the local microenvironment to enable many of the hallmarks of cancer we've just discussed.
How do they help the cancer?
In many ways. They can release growth factors that stimulate tumor cell proliferation. They can help remove growth suppressors, for example, by secreting proteases like MMPs that degrade the extracellular matrix, which not only facilitates invasion, but can also release matrix-bound growth factors. Certain tumor-associated macrophages, TAMs, can enhance resistance to cell death. They are major producers of VEGF, thus inducing angiogenesis. And they can actively promote invasion and metastasis, for example, by facilitating that EMT process.
So the body's own inflammatory cells get co-opted by the tumor to help it thrive.
Absolutely. It's a complete ecosystem that supports and accelerates the cancer's progression. This understanding has even led to some clinical observations, like the fact that long-term use of anti-inflammatory drugs like aspirin or specific COX-2 inhibitors seems to reduce the risk of developing certain cancers, particularly colorectal cancer, although the benefits need to be weighed against potential side effects.
Right. It's all interconnected. This all raises that really important question. Where do these many different cancers actually come from? Given how complex they are and how prevalent, what are the big picture causes and risk factors?
Well, looking globally, cancer remains the second leading cause of death worldwide, responsible for about 1 in 6 deaths. And unfortunately, the number of cases is projected to increase significantly in the coming decades, partly due to population growth, but also because populations are aging, and age is the single biggest risk factor for most cancers.
Right, more time for mutations to accumulate.
Exactly. Now, as you mentioned at the start, the U.S. has seen a welcome and sustained decline in overall cancer death rates since the early 1990s. That's really significant progress.
What drove that decline?
It's multifactorial. A huge factor, especially for lung cancer, was a reduction in tobacco use. Smoking rates went down, and eventually, lung cancer death rates followed, first in men and then in women. Also, improvements in screening and early detection, as well as more effective treatments, have made a big impact on death rates for colorectal, breast, and prostate cancers.
That's great news. But you also mentioned lung cancer in women.
Yes, a sobering trend is that lung cancer, primarily due to smoking, now sadly causes more cancer deaths in women in many Western countries than breast cancer does.
Wow. And age is the biggest risk factor overall.
For most common cancers, yes. The incidence rises steeply after age 55 or so, likely reflecting that accumulation of somatic mutations over a lifetime. However, cancer isn't just a disease of the elderly. Tragically, it's still a leading cause of death from disease in children under 15, accounting for maybe 10% of all deaths in that age group in developed countries.
And are children's cancers different?
Often, yes. They tend to be different types than adult cancers, more leukemias, brain tumors, sarcomas, and embryonal tumors. And they are more frequently linked to inherited mutations or developmental abnormalities rather than the accumulation of environmental damage.
Okay. Speaking of environmental factors, I remember hearing a joke, something like, it appears that almost everything one does to earn a livelihood or for pleasure is fattening, immoral, illegal, or even worse, carcinogenic. And it really feels like potential carcinogens are everywhere.
It shuffles. It can certainly feel that way sometimes, can't it? And environmental carcinogens definitely play a significant role in many cancers. Let's break them down.
Okay.
First, there's radiation. Ultraviolet UV rays from sunlight are clearly linked to skin cancers, squamous cell carcinoma, basal cell carcinoma, and melanoma. It's primarily the UVB component that's mutagenic, causing specific types of DNA damage. The risk depends heavily on the intensity of exposure, the type of UV, and importantly, an individual's skin pigmentation, which offers natural protection.
So sun exposure is a definite risk. What about other radiation?
Then there's ionizing radiation X-rays, gamma rays, radioactive isotopes. We have clear historical lessons from people like the early X-ray pioneers or radium dial painters, and tragically, from the atomic bomb survivors in Japan who showed a marked increase in leukemias within a few years, followed later by increased rates of various solid tumors like breast, colon, thyroid, and lung cancers.
So high doses are clearly dangerous. What about lower doses like medical X-rays or CT scans?
That's a more complex and sometimes controversial area. There is evidence, particularly from studies of children who received multiple CT scans, suggesting a small but measurable increased risk of developing leukemia or brain tumors later on. While the risk for any individual scan is very low, the cumulative dose matters, and there's a push to minimize radiation exposure, especially in kids. It's also known that different tissues have different vulnerability, bone marrow leading to myeloid leukemias, and the thyroid are particularly sensitive, especially in children.
Okay, radiation. What about chemical carcinogens?
Chemical carcinogens are a huge group. They generally fall into two main categories based on how they act. Direct-acting carcinogens don't require any metabolic conversion in the body to be damaging. They're inherently reactive. Interestingly, some potent examples are actually anti-cancer chemotherapy drugs, particularly alkylating agents. They work by damaging DNA in cancer cells, but they can also damage DNA in normal cells, which, tragically, can sometimes lead to secondary cancers, often acute myeloid leukemia, years later.
Wow, the cure can sometimes cause another cancer later.
It's a known risk, unfortunately, though usually outweighed by the benefit of treating the first cancer. The second category is indirect-acting carcinogens. These compounds are not necessarily harmful themselves, but they need to be metabolically converted within the body, usually by liver enzymes, like the cytochrome P450 system, into an ultimate carcinogen that can then damage DNA.
So the body accidentally activates them. What are some examples?
Many of the most potent chemical carcinogens fall into this category. Polycyclic aromatic hydrocarbons, PAHs, are a big one. They're found in fossil fuels, soot, produced during incomplete combustion, so they're in cigarette smoke, car exhaust, and also formed when grilling or charring meats at high temperatures. Benzoapyrene is a classic example.
Benzoapyrene from burnt toast or grilled steak.
Potentially, yes, though the levels matter. Aromatic amines and idosodies, used in some industrial processes and formerly in some food colorings, are another important class. Nitrosamines, which can be formed in the stomach from nitrates and nitrates used as food preservatives, are also implicated, particularly in stomach cancer.
Okay. And do these chemicals leave fingerprints? You mentioned mutational signatures.
Yes, that's a really exciting area of research. Direct carcinogens tend to cause specific patterns of DNA mutations, like specific base substitutions or types of DNA damage. These act like mutational signatures. For example, aflatoxin B1, a toxin produced by Aspergillus mold that can contaminate improperly stored grains, like corn and peanuts, is strongly linked to liver cancer, particularly in parts of Africa and Asia, and it causes a very specific mutation hotspot in the TP53 gene at codon 249.
Aflatoxin, right?
And cigarette smoke is another great example. Lung cancers in smokers have, on average, about a 10 times higher mutational burden than lung cancers in non-smokers. And they show very characteristic mutational signatures, particularly CD8 base substitutions, that are directly linked to the PAHs in tobacco smoke. We can literally see the imprint of smoking in the tumor's DNA.
That's powerful evidence. Okay, radiation, chemicals. What about infectious agents? Can infections cause cancer?
Absolutely. It's estimated that infectious agents account for roughly 15% of all cancers worldwide, maybe even higher in some developing regions. Several viruses, one bacterium, and even some parasites are implicated.
15%. That's significant. Which ones?
Let's start with the viruses. There's human T-cell leukemia virus type 1 HTLV1. It's a retrovirus, distantly related to HIV, and it causes a specific type of cancer called adult T-cell leukemia lymphoma, ATLL. It's endemic, meaning common, in certain parts of the world like southern Japan, the Caribbean Basin, and parts of Africa. It has a very long latency period, often 40 to 60 years, between infection and cancer development.
HTLV1. Okay, what else?
Then there's the very important human papillomavirus, HPV.
HPV, yes, linked to cervical cancer.
Primarily, yes. Specific high-risk types of HPV, particularly type 16 and 18, are responsible for almost all cervical cancers. But they're also implicated in the genesis of squamous cell carcinomas in the anogenital region, vulva, vagina, penis, anus, increasingly recognized as a major cause of cancers in the oropharynx, the back of the throat, tonsils, base of tongue, especially in developed countries now.
How does HPV cause cancer?
Remember those viral oncoproteins we talked about? The high-risk HPV types produce two key ones, E6 and E7. E6 targets P53 for degradation, and E7 binds and inactivates the RB protein. So the virus directly takes out our two main tumor suppressor guardians.
Disabling the brakes again.
Exactly. And the crucial public health message here is that HPV cancers can be prevented by vaccination against high-risk HPV types. The HPV vaccine is truly a cancer-preventing vaccine.
Extremely important point. Okay, what other viruses?
Epstein-Barr virus, EBV. There's a very common herpes virus. Most people get infected at some point, often causing mono. But EBV is also implicated in several types of cancer. It's famous for its link to Burkitt lymphoma, particularly the type endemic in parts of Africa. It's also linked to lymphomas that arise in immunosuppressed patients, like transplant recipients or those with AIDS, some forms of Hodgkin lymphoma, and almost all cases of nasopharyngeal carcinoma, which is common in southern China.
Burkitt lymphoma. Isn't that linked to malaria too?
Yes, the thinking for endemic Burkitt lymphoma is often a multifactorial hypothesis. EBV infection acts as a potent B-cell mitogen, causing B cells to proliferate. Then, chronic malaria might further impair immune control, setting the stage for a specific chromosomal translocation involving the MYC oncogene, usually T814, to occur in one of those proliferating B cells, driving the development of lymphoma. So it's EBV plus other factors.
Complex interactions. Any other major viruses?
The big ones for liver cancer are hepatitis B virus, HBV, and hepatitis C virus, HCV. Together, these two viruses are estimated to cause 70% to 85% of hepatocellular carcinomas worldwide.
Wow, the vast majority of liver cancer. How do they do it? Is it like HPV?
Not exactly by encoding oncoproteins like E6, E7. The main mechanism seems to be the chronic inflammation, liver cell injury, and resulting compensatory regeneration that occurs over decades of infection. This chronic cycle of cell death and proliferation creates a fertile ground for mutations to accumulate, eventually leading to cancer. Of course, HPV can integrate its DNA into the host genome, which might also directly contribute in some cases. And again, we have effective vaccines for HPV and now highly effective antiviral treatments for HCV, which should hopefully reduce liver cancer rates in the future.
Okay, so mostly chronic inflammation for HCV. Now, you mentioned a bacterium.
Yes. Helicobacter pylori. This was groundbreaking when discovered. H. pylori is the first bacterium classified as a carcinogen. It infects the stomach lining and is the main cause of peptic ulcers, but chronic infection is also strongly linked to two types of stomach cancer: gastric adenocarcinomas, the most common type, and a specific type of lymphoma called gastric malt lymphoma, mucosa-associated lymphoid tissue lymphoma.
How does a bacterium cause cancer? Inflammation again.
Chronic inflammation is definitely a major part of the story for the adenocarcinoma. H. pylori triggers a strong inflammatory response in the stomach lining, leading to gastritis, atrophy, metaplasia, and eventually dysplasia and cancer over many years. For the malt lymphomas, it's a bit different. The chronic inflammation stimulates the proliferation of B cells in the stomach lining, and eventually one might acquire mutations that make it grow independently. Interestingly, for early-stage malt lymphomas, sometimes simply eradicating the H. pylori infection with antibiotics can cause the lymphoma to regress.
Treat the infection, treat the cancer. Amazing.
It really is. It highlights the diverse ways microbes can contribute to cancer development.
Okay, so we've covered the hallmarks, the enablers, the causes. Now let's shift to the patient experience. Beyond the obvious impact of a tumor just growing and taking up space, What else does cancer do to a person? What are some of the other clinical manifestations?
Right, the effects of a tumor go far beyond just its physical presence. Even benign tumors can cause significant problems simply due to their location and the pressure they exert. We mentioned pituitary adenomas compressing brain tissue, or tumors in the gut causing obstruction. Tumors can also ulcerate and bleed, leading to anemia.
Right.
And sometimes, ironically, a local effect can be a fortuitous obstruction that leads to an earlier diagnosis than might otherwise happen, like a small pancreatic cancer blocking the bile duct, causing jaundice, yellowing of the skin. That symptom sends the patient to the doctor, and the cancer might be caught at an earlier, potentially treatable stage.
A blessing in disguise, in a way.
In a very grim way, perhaps. Tumors arising in endocrine glands can also cause problems by producing hormones, sometimes in massive excess. Even a benign pancreatic beta cell adenoma, an insulinoma, can produce so much insulin that it causes potentially fatal hypoglycemia, low blood sugar.
So local effects and hormonal effects? What about more systemic problems?
One of the most devastating systemic effects is cancer cachexia.
Cachexia. That's the severe wasting, right?
Yes, it's a profound hypercatabolic state defined by a loss of muscle mass, often accompanied by loss of fat as well. It affects about 50% of cancer patients, particularly those with advanced solid tumors, and is estimated to be directly responsible for about 30% of cancer deaths.
30%, just from the wasting.
Directly or indirectly, yes. It's characterized by extreme weight loss, profound fatigue, muscle atrophy, often anemia, and anorexia, loss of appetite. It severely impacts quality of life and the patient's ability to tolerate treatment.
What causes it? Is it just not eating enough?
Anorexia is part of it, but it's much more complex than just starvation. Cachexia seems to be driven by systemic inflammation and metabolic changes induced by the tumor and the body's response to it. Inflammatory mediators, cytokines like tumor necrosis factor, TNF, IL-1 and IL-6, appear to play important roles in driving muscle breakdown and altering metabolism. It's an active process of wasting, not just passive lack of intake.
That sounds truly awful. Are there other systemic effects?
Yes, another important category are the paraneoplastic syndromes.
Paraneoplastic, meaning alongside the cancer.
Exactly. These are signs and symptoms that cannot readily be explained by the anatomic distribution of the tumor itself or by hormones that are normally produced by the tissue from which the tumor arose. They are remote effects of the cancer.
Okay. How common are they?
They occur in maybe 10–15% of cancer patients, and they are incredibly important to recognize for several reasons.
Why is that?
First, a paraneoplastic syndrome may be the earliest manifestation of an occult neoplasm, meaning it might be the first clue that someone has an underlying cancer that hasn't been found yet. Second, they can cause significant clinical problems and may even be lethal in their own right, regardless of the cancer itself. And third, they may mimic metastatic disease and therefore confound treatment decisions if not correctly identified as paraneoplastic.
So they can be the first sign, a major problem themselves, or confusing. It sounds really important to know about them. What's particularly fascinating is how widespread these distant effects can be, affecting seemingly totally unrelated parts of the body. Can you give us a few examples of these surprising syndromes?
Certainly. There are many types. Endocrinopathies, hormone-related syndromes are common. A classic example is Cushing's syndrome caused by excessive cortisol. While usually due to pituitary or adrenal problems, it can be caused by, say, a small cell lung carcinoma producing ACTH ectopically, the lung tumor making a hormone it normally shouldn't, which then stimulates the adrenals to make cortisol.
A lung tumor causing Cushing's. Wow.
Or hypercalcemia, high blood calcium is another common one, sometimes caused by tumors secreting parathyroid hormone-related protein, PTHrP, which mimics parathyroid hormone. Then there are neuromyopathic syndromes. These can involve the immune system, perhaps triggered by a tumor antigen that cross-reacts with proteins in the nervous system, leading to muscle weakness, like Lambert-Eaton syndrome, peripheral neuropathy, or even cerebellar degeneration.
The immune system attacking the nerves because of the cancer.
That seems to be the mechanism in many cases. We also see dermatologic or skin manifestations. Acanthosis nigricans, which causes darkened, velvety thickening of the skin, especially in body folds, can be associated with underlying cancers, particularly stomach cancer. Or the lesser trilotzyme, which is the sudden eruption of numerous itchy, wart-like skin lesions called seborrheic keratosis, also often linked to internal malignancy, especially gastric carcinoma.
Skin signs hinting at internal cancer.
Yes. And vascular or hematologic syndromes are also well known. For instance, migratory thrombophlebitis recurrent, unexplained blood clots appearing in different veins is known as Trousseau syndrome, and is often associated with underlying pancreatic or lung cancer. Tumors can activate the clotting system.
Trousseau syndrome. Okay, so lots of potential remote effects. Now, when doctors diagnose cancer and try to predict how it will behave or choose treatment, they use grading and staging, right? What's the difference?
Yes, grading and staging are two fundamental ways we assess a cancer, but they measure different things. Grading is based on the microscopic appearance of the tumor cells. It focuses on the degree of differentiation, how much the cancer cells still resemble their normal counterparts, as well as the number of mitoses, dividing cells, and sometimes other architectural features. It's essentially an attempt to judge the tumor's intrinsic aggressiveness based on how abnormal it looks under the microscope. Grades are often given as grade 1, well-differentiated, low grade, up to grade 3 or 4, poorly differentiated or an anaplastic high grade.
So grading is about how ugly the cells look.
Tuckles. That's a blunt way to put it, but yes, essentially how abnormal they appear. And while histologic grading is useful, it's important to realize that the correlation between histologic appearance and biologic behavior is less than perfect. Some low-grade tumors can still behave aggressively, and vice versa.
Okay, so what's staging then?
Staging generally is considered of greater clinical value than grading for predicting prognosis and guiding therapy for most solid tumors. Staging is based on the anatomic extent of the cancer. It assesses size of the primary lesion, whether it has spread to regional lymph nodes, and crucially, the presence or absence of blood-borne metastases.
How far has it spread?
Exactly. The major system used worldwide is the T&M system, developed by the AJCC and UICC. T stands for the size and the local extent of the primary tumor. N stands for the involvement of regional lymph nodes. And M stands for the presence of distant metastasis. Each factor gets assigned a number. You're at VT1, T2, N0, N1, M0, M1. And these are combined to determine an overall stage, typically stage I, localized, through stage 5, metastatic.
T, N, M tumor, nodes, metastasis. That makes sense.
And staging is critical because generally, higher stage correlates with worse prognosis and often dictates different treatment approaches. However, it's also becoming clear that for many cancers, specific molecular features of the tumor can provide crucial prognostic information that complements or sometimes even overrides the anatomic stage.
Right.
So molecular profiling is increasingly integrated with staging.
Right. It sounds like the diagnosis of cancer is just becoming incredibly sophisticated and, as you say, personalized. Speaking of these cutting-edge tools, this really feels like where the science is leaping forward almost daily. How are things like DNA sequencing and these omics technologies revolutionizing how we diagnose and fight cancer?
You're absolutely right. The advancements in the last decade or two have been truly astounding. We've moved far beyond just looking at cells under a microscope, although that traditional histology and cytology like the Pap test for cervical cancer, looking for abnormal cells, remain fundamental.
Still the foundation.
Absolutely. But now we layer on incredibly powerful tools. Immunohistochemistry, or IHC, has become indispensable. We use specific antibodies to detect proteins in tissue sections. This allows us to precisely categorize undifferentiated tumors, for example. Finding cytocuratins confirms an epithelial origin, carcinoma, while vimentin suggests a mesenchymal origin, sarcoma.
So identifying the cell type by its protein markers.
Exactly. IHC can also help determine the site of origin for a metastatic tumor when it's unclear. Detecting PSA strongly suggests prostate cancer. Thyroglobulin points to thyroid cancer. And crucially, IHC detects key prognostic or therapeutic markers. Think of testing breast cancers for estrogen receptors, progesterone receptors, and HER2 amplification status. This directly guides whether hormone therapy or anti-HER2 therapy will be effective. Or testing lung cancers for ALK protein expression, which predicts response to ALK inhibitors.
Guiding targeted therapy. Essential now.
It's essential. Flow cytometry is another powerful tool, especially for liquid tumors like leukemias and lymphomas. It uses lasers and antibodies to rapidly analyze individual cells in suspension, identifying different cell types based on the markers on their surface, which is crucial for classifying these complex diseases.
Okay, IHC and flow, but the real revolution seems to be in sequencing, right? The omics.
Yes. The impact of high-throughput DNA and RNA sequencing has been transformative. Large-scale projects like the Cancer Genome Atlas, TCGA, have mapped the genomic landscapes of thousands of tumors across many cancer types. We can now generate these incredibly detailed Circos plots that visualize all the mutations, deletions, amplifications, and rearrangements in an individual tumor's genome.
Seeing the whole blueprint of the cancer's errors.
Precisely. And these molecular analyses have several critical clinical applications now. First, as we touched on, they provide powerful information for prognosis and therapy stratification. independent of stage sometimes. For instance, finding NMYC amplification in a neuroblastoma tells you it's likely to be very aggressive. Finding specific deletions, 1p19q co-deletion in an oligodendroglioma brain tumor, predicts a much better response to chemotherapy and longer survival.
To predicting outcome and treatment response from the genes.
Exactly. Second, molecular tests allow for highly sensitive detection of minimal residual disease, or MRD. After treatment, we can look for trace amounts of cancer cells by detecting their specific mutations or fusion genes, like BCR-ABL transcripts in CML patients after therapy. If MRD persists or reappears, it signals a high risk of relapse and might prompt further treatment.
Catching recurrence super early.
That's the goal. Third, molecular testing is crucial for diagnosing hereditary predisposition to cancer. By sequencing genes like BRCA12 in families with histories of breast and ovarian cancer, or RET in families with multiple endocrine neoplasia, we can identify individuals at high risk and offer them intensified screening or even prophylactic surgery, like mastectomy or oophorectomy, to prevent cancer from developing.
Preventing cancer before it starts in high-risk people.
A huge advance.
Yeah.
And fourth, perhaps the biggest impact currently, is guiding oncoprotein-directed drugs. Identifying specific driver mutations or alterations is now essential for optimal treatment for many cancers. This represents a true paradigm shift away from one-size-fits-all chemotherapy towards precision oncology. We've mentioned several. The PMLA or A fusion in APML guiding differentiation therapy with ATRA and arsenic. The BCR-ABL fusion in CML guiding treatment with imatinib and other kinase inhibitors. EGFR mutations or ALK rearrangements in lung adenocarcinoma guiding treatment with specific targeted inhibitors like osimertinib or alectinib. BRAF mutations, specifically V600E, in melanoma guiding treatment with BRAF inhibitors like vemurafenib, often combined with MEK inhibitors. The list is growing rapidly. We sequence the tumor, find the driver, match it to the drug.
Find the target, hit the target.
That's the principle. And an incredibly exciting, rapidly developing field related to this is liquid biopsies.
Liquid biopsies, taking blood instead of tissue.
Essentially, yes. The idea is to analyze tumor material, either intact, circulating tumor cells, CTCs, or increasingly fragments of cell-free DNA, cfDNA, that tumors shed into the bloodstream. By sequencing this cfDNA, we can often detect the same mutations found in the tumor tissue, but non-invasively through a simple blood draw.
What's the main goal of that?
The huge potential is for monitoring treatment response and detecting resistance. The ultimate goal: detect the early emergence of new genetic variants that convey drug resistance before the patient shows clinical signs of relapse. This would allow oncologists to anticipate resistance and potentially switch to alternative, more effective drugs preemptively, staying one step ahead of the evolving tumor. It could also be used for earlier cancer detection in the future, though that's still challenging.
Real-time tracking of the cancer's evolution through blood tests. Incredible. What about traditional blood tests like tumor markers, PSA, CEA, where do they fit in?
Right. Tumor markers like PSA, prostate-specific antigen for prostate cancer, CEA, carcinoembryonic antigen for colorectal, pancreatic, and other cancers, AFP, alpha-fetoprotein for liver cancer or germ cell tumors, HCG, human chorionic gonadotropin, for testicular cancer. These have been around for a while. They are proteins, or sometimes hormones, that can be elevated in the blood of cancer patients.
Are they good for screening? Finding cancer early in healthy people?
Generally, no. That's a critical point. Most traditional tumor markers lack the sensitivity. They miss too many cancers. And importantly, the specificity, they can be elevated by benign conditions too, needed for effective population screening. For example, PSA can be elevated by benign prostatic hyperplasia, BPH, or prostatitis, leading to many false positives and unnecessary anxiety in biopsies if used broadly for screening.
So, not great for screening. What are they useful for?
Their main utility is in monitoring patients already diagnosed with cancer. They can be very helpful for assessing response to therapy. If the marker level goes down, the treatment is likely working. And they are useful for detecting recurrence. If a marker that went down after treatment starts rising again, it strongly suggests the cancer is coming back, often before it's visible on scans. So valuable for management, but generally not for initial diagnosis or screening in the general population.
Monitoring, not screening. Got it. That's a crucial distinction. So, wow, we've covered a huge amount of ground. What does this all really mean for the future of cancer? We've taken this journey through its incredible complexity from the frankly confusing nomenclature and the subtle microscopic clues pathologists look for, to its intricate molecular playbooks, the environmental triggers, and these astonishingly sophisticated tools we now have for diagnosis and treatment.
It's been a remarkable journey of discovery, hasn't it?
It really has.
Yeah.
And we've seen tremendous progress, especially with targeted therapies and immunotherapies. We've moved from these broad, often brutal, blunt instruments towards incredibly precise, sometimes personalized intervention.
Absolutely have.
Listening to all this, especially about the genomic instability, the heterogeneity, the cancer stem cells, the constant evolution, it feels like the cancer itself is always adapting. That genetic heterogeneity and epigenetic plasticity, the cancer's ability to change its spots, essentially within individual tumors, mean that finding a single cure might be the wrong way to think about it.
I think that's a very insightful point. For many advanced cancers, it may look less like searching for a single magic bullet and more like developing an ongoing, highly personalized and adaptable strategy. One that's tailored not just to the initial tumor, but to the evolving nature of each patient's specific cancer over time.
Like managing a chronic evolving disease rather than aiming for one knockout punch.
For many situations, that might be a more realistic paradigm. Continuously monitoring the cancer's evolution, perhaps through those liquid biopsies we discussed, and adjusting the therapy accordingly as new resistance mutations emerge or new vulnerabilities appear.
So the provocative thought for you, the listener, might be this. What new technologies will emerge to map this cancer evolution in real time? Could we get to a point where simple, frequent blood tests can guide therapy dynamically, responding instantly to every twist and turn the disease takes? How do we stay ahead in this incredibly complex, adaptive biological chess game?
That's the challenge and the immense opportunity driving cancer research today.